All right, hey, how's it going, everybody? Surprise, I'm actually going to record 2 episodes today. So we finished off the dermatopathology or the skin sections of Kurt's notes, and I wanted to do another section. So this is from the head and neck portion of Kurt's notes. And I want to talk a little bit about ear lesions, primarily because I had a few ear shave biopsies this past week, and it's also kind of derm related. The ear is, after all, covered in skin. So let's get started. So there's some congenital lesions of the ear that you can get, which is an accessory tragus is one of them. This is a developmental anomaly that recapitulates normal external ear with a central cartilage, as shown here by 1, surface skin, and adnexal structures. So this is just an accessory tragus located on the skin surface anterior to the auricle, and usually identified in childhood, and it's cured by excision, so you can just surgically remove them. All right, and next up we have encephalocele. So an encephalocele is herniation of brain tissue, which is continuous with brain. Variable portions of neurons and glia, which will stain positive for GFAP, often with gliosis, chronic inflammation, and fibrosis, and the meninges are usually absent. Histologically, these are indistinguishable from glial heterotopia, which is discontinuous from the brain. All right, so some inflammatory or reactive lesions of the ear. You can have otitis media, extremely common clinically, not usually sampled for pathology, however, often caused by viral or bacterial infections of the middle ear. Most common in young kids, they get an ear infection, usually resolves on its own. You can have acute and or chronic inflammation with fibrosis, and entrapped epithelial inclusions can be mistaken for tumor. So be mindful of that. Next up, you've got an otic polyp. So this is a reactive response to long-standing otitis media. You get granulation tissue with dense chronic inflammation, as shown here. And you may have entrapped surface epithelium with cholesterol clefts or calcifications. Next up, I actually had this case, or a case of this entity this past week, which was exciting because I got it right. Probably because I looked at Kurt's notes. But this is a chondrodermatitis nodularis helicus, or CNH. So the 3 factors or 3 things you want to look out for with the CNH is surface hyperplasia surrounding ulceration with a keratin plug, dermal fibrinoid necrosis, and necrotic cartilage, usually. And that's because it's on the ear, remember, and we have a lot of cartilage in our ear covered by skin. So this often occurs on the helix or anti-helix of the ear. It's a localized injury and clinically can be mistaken for squamous cell carcinoma. So one thing I actually noticed about this case, in my case in real life, and then I learned about it in Dr. Gardner's survival guide, is on either side of this ulceration, you have this vascular proliferation. So that kind of makes sense, right? Like this area is damaged, so maybe the body's trying to respond with more blood vessels to try to get nutrients to help repair it. So you can't really see it as much on this side, but I imagine it's also there, but you have this vascular proliferation. And it was quite prominent in the case that I had this past week, so that was kind of helpful. All right, next up we have a steatoma. Can't say I've pronounced that one many times in my life, so I apologize if I mispronounced it. So this is a keratinizing cyst in the middle ear. It destroys ossicular chain, and it leads to conductive hearing loss and foul-smelling discharge. There's 3 required components of a cholesteatoma. So you want to have stratified squamous epithelium with a granular layer, as seen here with number 1. Number 2, you want to have that keratinaceous debris. 3, you want to have an inflamed fibrous stroma. And these are frequently associated with cholesterol clefts and foreign body giant cell reaction. They can be secondary to chronic otitis media or congenital, and they can be locally destructive and recur. Next up, we've got otosclerosis. So this is bone overgrowth with fixation of ossicular chain leading to conductive hearing loss, and it's an unclear etiology of where otosclerosis comes from. You can have immature trabecular bone and vascular stroma with varying appearance in different phases. These are usually bilateral and symmetrical. Moving right along, so we've got some benign neoplasms of the ear to go over. All right, so this is a middle ear adenoma, also known as a Mimi-net, or a middle ear mixed epithelial neuroendocrine tumor. This is a rare neoplasm with dual neuroendocrine and mucin secreting differentiation. It can be infiltrated, unencapsulated, with multiple patterns of growth, glandular, trabecular, diffuse, nested, and more. The ducts show dual cell population. So you have an inner luminal flattened eosinophilic cells with secretion and an outer cuboidal or columnar cell with a delicate salt and pepper chromatin. And for IHC, these middle ear adenomas are going to be positive for cytokeratin, synaptophysin, chromogranin, and mucin stains with PAS and Alshin blue. And these are found in the middle ear, hence the name middle ear adenoma. All right, next up we've got Ceruminous adenoma. This is a benign tumor of the wax-producing glands of the external auditory canal. Unencapsulated, circumscribed often, bilayered glands in a fibrous stroma with inner luminal secretory cells with abundant granular cytoplasm and yellowish ceroid secretions. Cytokeratin 7 positive, and also positive for basal myoepithelial cells markers like P63 and S100. There's a variety of growth patterns for ceruminous adenoma, and it can overlap with pleomorphic adenoma and syringocystadenoma papilliferum. Some other tumors to be aware of, other non-unique tumors and tumor-like lesions include paraganglioma, meningioma, schwannoma, exostosis, malakoplakia, keloid, Langerhans cell histiocytosis, synovial chondromatosis, and epithelioid hemangioma. All right, this is our last page. We're going to go over some malignant neoplasms that can occur in the ear. First up, we've got squamous cell carcinoma. So this is a malignant neoplasm of the squamous epithelium. Similar to squamous cell carcinoma elsewhere on the skin, it's an invasive carcinoma with frequent keratinization and inflamed desmoplastic stroma. So you have this nice keratin pearl here, and most cases are external ear and UV related, usually in the elderly with pre-existing actinic change. Next up, we've got endolymphatic sac tumor. This is a low-grade malignant, locally destructive tumor arising from the endolymphatic sac in the petrous temporal bone. These are very rare, but associated with von Hippel-Lindau in about a third of the cases. Unencapsulated and invasive architecture, and it can also be papillary and cystic. Histologically, you're going to see clear to pale pink cells with eccentric nuclei, usually arranged in a single layer with small, round, hyperchromatic nuclei, and they may have pink, PAS positive secretions. For IHC, endolymphatic sac tumors are going to be cytokeratin, EMA, S100, SOX10, PAX8, and CA9 positive. However, they're going to be negative for CD10, RCC, and TTF1. All right, lastly, we have ceruminous adenocarcinoma. So these are rare malignant neoplasms derived from the ceruminous glands of the external auditory canal. They are infiltrative with variable architecture, solid, cystic, cribriform, glandular, and more. and frequently have perineural invasion and necrosis with biphasic cell populations like their benign counterpart. And cytologic pleomorphism is going to be seen in the adenocarcinoma, which makes sense because it's a malignant, as well as mitoses and no ceroid pigment. You can differentiate to or be histologically identical to adenoid cystic carcinoma or a mucoepidermoid carcinoma. So good thing to have on your differential and to think about, especially in the ear. So yeah, just a quick video. I hope you all enjoyed that. Thank you for lending me your ear today, and take care.